new technologies played an important role in their treatment and pushed far away our surgical possibilities. For many reasons, such as the pedicle size, the vertebral orientation, and the complexity of the anatomy, navigation is, in my opinion, one of the most interesting tools that we have added to our technology in the last decade. It allows, at the same time, better positioning of the implants, but more important is that it permits to control the vertebral resection that permit a safer and more effective correction. Let's start with idiopathic etiology. The most frequent curve, including the upper thoracic curve inside the fusion, is mandatory for two reasons. The first is to balance the shoulder height. The second is to avoid junctional kyphosis. Here you can see a first example. And here you can see a second example. On the contrary, here we can see a junctional kyphosis between the upper and the lower curve. The surgeon started by treating the lower thoracic curve by anterior approach, then posterior approach, not taking into account the upper thoracic curve. A junctional kyphosis occurred between the two thoracic curves. In situ instrumented fusion was then performed, and the implants were then partially removed because of their prominence and their conflict with the skin. I saw the patient after all these surgeries. She was complaining from a severe upper thoracic kyphosis, leading to cervical hyperlordosis, which was painful. There is an angular deformity centered on T5. Here you can see the 3D reconstruction showing the absence of landmark at the fusion area. During surgery, we may face many difficulties, starting from positioning to approach, then to find the direction for the upper thoracic screws, and ending with the correction maneuver. And of course, how to control the resection. We described a specific technique for PSO at the upper thoracic spine using navigation and external maneuver of correction with Mayfield frame. Here you can see the two references for that. As we just said, navigation is useful to control screw insertion, but especially to control the amount of vertebral resection. Mayfield frame will stabilize the proximal segment. During vertebral resection, it is very important to leave 0.5 to 1 centimeter of bone anteriorly that help to avoid instability and vertebral translation. Associated to the Mayfield frame fixation, there is no need for temporary rods in our technique. We usually include the disc above inside the resection, performing what we already described as modified closing opening wedge osteotomy, or MCO, that allows to increase the amount of correction without excessive shortening. Here you can see the photo of the spinal column before and after the correction. Here you can see the X-rays of the patients. And here you can see the correction of the deformity, but also, which is very important, the normalization of the compensatory mechanism. And here you can see the result after fusion 1 year after surgery. This is another case of post-traumatic deformity at the cervicothoracic junction and treated by T5 PSO. You can see here the correction on the coronal and sagittal plane. After iatrogenic deformities, the second etiology of upper thoracic and lower cervical deformities is neurofibromatosis. In this neurofibromatosis case, navigation helped to identify the level of the rib head dislocation and allowed to remove it before any correction. Navigation is an interesting technique to use in case of congenital anomalies. It permits an accurate implant insertion, but as we said, also a continuous control of the vertebral body resection. Here you can see the results after resection and correction. The arrows show the resection of the ribs. Congenital malformation is another etiology for cervicothoracic deformities. This is one example. It is an adolescent with a neglected upper thoracic congenital scoliosis. Before surgery, we can see the effect of the upper thoracic curve on the cervical spine with a very severe oblique takeoff of C7. 3-column osteotomies was necessary to improve the coronal plane. You can see the correction of the main curve, but especially the correction of the cervical curve and the horizontalization of the C7. In this younger patient, the cervicothoracic congenital deformity was treated by a convex epiphysiodesis by posterior approach. Here you can see the result at the immediate postoperative period and at 4 years follow-up. We must know that convex growth arrest can avoid curve progression and may lead to progressive correction of the deformity in younger age. The last etiology we will talk about is syndromic. Syndromic spinal deformities may be located at the cervicothoracic junction, like in this case of Larsen disease. In this last case of a very severe kyphoscoliosis, including cervical and thoracic spine, we can see a progressive lengthening by multiple Majek rods from age 6 to age 13. Here you can see after multiple ponte osteotomies that we obtained a good correction of both curves, especially the cervicothoracic kyphosis. What I may learn from this case is that even in severe cases, posterior column osteotomies may be an option, and that all severe deformities do not need 3 columns osteotomies. As I take home messages, I may say that cervicothoracic curves are really idiopathic, and one should be careful to treat the upper thoracic curve in Linke type 2 to avoid shoulder imbalance and C7 obliquity, but also to avoid junctional kyphosis between the upper and the lower thoracic curves. Syndromic and congenital etiology associated to iatrogenic etiology are the most frequent. Navigation controlled osteotomies is a valuable tool, and I think it permitted to improve the quality of our surgery and to push our limits. Thank you for your attention.